It's my pleasure today to introduce, or at least partially introduce, one of the two speakers and introduce the other speaker. But we have two presenters today, Dr. Jenny Chong from who's an associate professor of family and community medicine in our medical center. And she's a co-investigator along with Dr. Francisco Moreno of our department in the study that they'll be discussing. And so that's a brief mention about Dr. Chong. Dr. Moreno will be introducing her further as she comes to the podium. So let me say a few words about Dr. Moreno. I think most of you know that he's not only a professor of psychiatry in our department, but also the interim department head. He has been conducting research in biology and the treatment of mood disorders as well as anxiety disorders that are geared to improve our understanding of brain issues and the brain basis for mental illness and underlying mechanism of action of antidepressant medications, anti-anxiety drugs, and also treatment resistance. His work is funded by grants from the National Institutes of Health, private foundations, and collaborations with industry. He has supervised and mentored a number of interdisciplinary students, psychiatry residents, research fellows, and junior faculty. His clinical interest and expertise include treatment-resistant mood and anxiety disorders, and he has written extensively on these topics. Dr. Moreno serves often as a psychopharmacology consultant to government institutions, health insurances, and the pharmaceutical and device industry. He is originally from Mexico, where he obtained his MD from the University of Baja California and then completed his psychiatry residency and research training in neuropsychopharmacology at the Arizona Health Sciences Center. He has a special interest in working with the underserved and has established clinical, educational, and research collaborations geared toward increasing the gap of mental health services for immigrants. Geared toward decreasing the gap of mental health services for immigrants in Arizona. And it's that interest that both Dr. Moreno and Dr. Chong will be discussing this afternoon. Their topic is entitled "The Use of Standard Internet Webcam in the Treatment of Hispanic Patients with Major Depressive Disorder." Dr. Moreno.
Thank you, John. My name is Francisco Moreno, and I approve that message. Thank you for coming in today. As John mentioned, my background is not in health outcomes research, but primarily in psychopharmacology and neurobiology of mood, anxiety disorders, things of that nature. And a few years back, as my wife and I were thinking, hey, what are we going to do when we're older? And I said, you know, one of the things that I really would like to do is to work with immigrants. And as you start talking to your friends about these kinds of things, everybody's like, well, why do you have to wait till you retire to do that? And kind of little by little got started with working in collaboration with St. Elizabeth Health Center. And through that initial collaboration, Jenny and I ended up having a really interesting larger scale pilot study that I hope is going to take us to further into the field of understanding and moving the field forward in terms of how to help decrease the disparities in healthcare in our community here in Tucson. So we're going to talk about a few things today, and I was told that I need to stay here, so I'll try to stay under the spotlight. And can everybody hear me okay in the back? Yep? All right. Very good. So we'll talk about demographics and needs of border states in terms of mental health issues, challenges for the provision of services in these communities, and then using the example of our study for the second or the later two-thirds of our conversation today to talk about a randomized control study of webcam telepsychiatry versus usual care provided by primary care physicians and extenders at a federally qualified community health center. That's quite a mouthful. All right, so as we get going, we have now data from the census in 2010, which basically indicates that the numbers that you see in this picture are now bigger bars extending a few percentage points pretty much uniformly throughout these 4 states. And what we have here is data indicating the percentage of Hispanics in these states like New Mexico, California, Texas, and Arizona. In Arizona, it indicates that we have about 25% of Hispanics. If you look at Tucson, the city of Tucson per se is greater than 40%. Pima County is greater than 33%. And the state as a whole is about a quarter of the population of the state. So it's a large population that continues to grow, and we're not really sure how to deal with that. There's a lot of unique needs that the population has. There's cultural, social, and racial factors that really affect how people perceive their illness, how people perceive their need for intervention, what kind of interventions, and their access to care as well. So hopefully we'll kind of review in a light way some of those aspects so that we can leave a little bit more time today to talk about the actual study design and the outcome that we have, which I think is the punchline of the day. Okay, so a few years back, I read a book by a guy named Gregory Fox. Gregory Fox is a ex-professor of anthropology here at the college of at the university, and he wrote this book called Hispanic Nation. And I was really intrigued by that because when I came here about 20 plus years ago, I was just a guy from Hermosillo, and then all of a sudden I was a Hispanic. Or was I a Mexican American? Or was I a Latino? Or I really didn't know what I was. I just saw myself as Mexican. And little by little, I have changed my mind about what I am. And so have changed other people about what people like me should be called, or why we should be grouped in a given category. So reading through that was really, really interesting as you read from an individual who had a different background, but had spent the majority of his professional life trying to understand the subtleties of what makes or breaks up the culture of Hispanics in the country. Starting with the name, Hispanics, Latinos, how should we call ourselves? And as he talked about the composition of this group and what are the nexus that put it together, namely Univision and Telemundo, basically was really dedicating chapters among this group to many of these pieces that are now discussed in the scientific literature about what constitute heterogeneity within this population. And of course, we have people within the Hispanic group that were born in different continents. People that were born in South America, in the Iberic Peninsula, or that were born in East LA, or in a ranch in the southeast part of Mexico. And of course, depending on where you were born, you may speak a different language. You may not speak Spanish. You may be very indigenous in your gene pool, or you may be more Caucasian than others, or you may be more African than others. There's also variations, not only in the places that we're coming from, but who we're hanging out with, the literacy that we're bringing, the understanding of the culture, and the degree of acculturation into the American general culture. So all these variations, of course, will have an important influence on how one individual perceives stress, experiences health, mental health, and the need for services, and the risk for those services as well. In Arizona, I think it's a place that really reflects the importance of this curve. Over time, since the 1850s to the current date, the percentage of, or the numbers of people that were born outside of the United States have continued to increase. And right now, we have 32% of those that are foreign born in the United States were born in Mexico. And so what that tells us is this represents a great challenge in order to be able to provide services to folks that are immigrants from another country that again, bring a different culture and different language, and that will require specifically congruency when they're being approached for treatment as well. We talked about some of the differences, but we're in looking at some of the demographic changes. The Hispanic group is a young group. If you look at the nurseries in most of the local hospitals, you'll find a lot of kids with very dark hair, lots of hair, skin that's a little bit not too light, and that kind of gives you an idea of sort of the racial background of a lot of the kids that are being born in our community. We have very young people, and these young people are also the ones that are having more babies, so this is a trend that we expect that will continue for at least another 2 decades. Also, people from the Hispanic background are more likely to speak a foreign language at home. Most of the time is Spanish, and a good chunk of them, 4 times or 5 times as much as the general population, do not speak English very well. Not very highly educated. About half of the people that are greater than 25 years of age have an equal or greater than high school education. It's a good working bunch, although it's a younger group. The percentage of people that are working is very similar to the general population, although they don't make as much money and they don't have as much insurance. And we have about 80% greater rate of poverty among Hispanics than among the general population in the United States. And remember, this is the general population, not only a Caucasian population subset. So when people come into this country, and if we recognize that the Hispanic group is a group that 40% was born in another country, they're also facing a series of challenges that lead to stress during immigration. Adaptation to the new culture is a big stress. Not having all the resources that you could, not being able to move as much, sometimes being blamed for a lot of what's going on. When times are hard, there's a lot of that going on. And a lot of these folks are vulnerable to being exploited, mistreated, and they don't always have the protection of the law, independently of their immigration status. Very importantly also, it's the role of individuals changes when people move here. And sometimes folks had identified themselves with a role within the family that may not be sustained when they move to a different culture that does not support some of the values that the individual had back at home. So we talked about people being more likely to be uninsured. If you're living in the border area, I don't know that we have any psychiatrists really that are practicing in Nogales and in the Douglas area. And so it's not as easy to have access to mental health services. A lot of the community services that folks receive through a regional behavioral health authority and otherwise are provided through telemedicine, and so it becomes a larger challenge to hire somebody that is going to be providing telemedicine services that will also speak your language and who also understand your culture, which is a very important piece when it comes to psychiatry, because a lot of people in the medical field, and we witness that in this hospital, do a wonderful job at trying to do a nice physical exam, at exploring the symptoms that an individual has, which is really nice in surgery. But when you're really trying to talk about these very complex issues that have to do with people's development, history of psychological conflicts, trauma, and other delicate things, it's really, really important to know that, that you're doing that in a sensitive way and in a way that is reflecting the values of the individual that you're interviewing. People are also less likely to give you what symptoms they have in a language that is not their own. And sometimes if we say, oh, I'm going to talk to you in Spanish, and let me go ahead and do the history that way, it may not even be the best choice for people. So sometimes moving back and forth and using bilingual information may be even better than just single language, even if it's the language of preference for an individual. That's particularly true in second-generation folks that have some degree of the lingual inheritance of their parents, and also some from the new culture that they're receiving. And without spending a lot more time on this, DSM-4, of course, recognizes a cultural formulation as one of the appendices for what could be used to supplement the multi-axial diagnosis. But what's important here is that the meaning of illness and in relation to how an individual perceives what's going on is really going to have an important effect on health seeking and what kind of treatments people are going to be accepting. We did a study here some years back, and we were comparing acupuncture for people. And when we did that study, we had about 12 other studies for depression going on. We had a very busy psychopharm group. And at the time, we were trying to figure out how do we assign people to the different studies. And rather than asking people, hey, so we have this menu of studies, which one would you like to be on? We figure if we're going to be doing that, we're going to be biasing who goes into a natural remedy study and who goes into a pharmacological study, who's willing to take a placebo-controlled study or not. So we started asking people, what's your perception of illness? What do you think is your problem? How do you think it would get better? And what are you willing to do for these kinds of treatments? And it was really eye-opening to see how people have really different perceptions of what is bringing them for care and what is going to help them. So depending, again, on the culture, the literacy, and sometimes the marriage of literacy within your culture that really helps influence what kind of interventions people are going to be comfortable with. So probably won't be spending so much more time on this, and moving then a little bit to what is the study that we're doing. This study that we're going to be discussing today is, again, a collaboration between the University of Arizona, College of Medicine, Department of Psychiatry, and the St. Elizabeth Health Center, formerly St. Elizabeth of Hungary Clinic. St. Elizabeth, it's a place that was founded by the Catholic Archdiocese here in town a number of years back, and they were really targeting the treatment of folks that were not insured. And of course, the need for that kind of service in the community has exploded. And as we know, with the continuous drop in services for mental health to people in our community, more and more people end up without being eligible for services through the REBAs. Those that are not access eligible, those that are Title 19 eligible, have to find other sources of care in the community. And St. Elizabeth is a place that has been overwhelmed with the demand for mental health services. They have a very large population of folks that are Spanish-speaking only, and they have a lot of people that are new immigrants also. Recent immigrants to the country and to the state. So the need for these folks to have services, it's challenged not only by the fact that they are not always eligible for entitlements, but we don't have trained personnel that is able to reach out and provide the services that they're needing. So because we had an interest in doing some work with them, I had been doing some along with some of the residents here at the clinic, some telemedicine service, and we were seeing some of their patients at the clinic through teleservices at our clinic, and they found that very useful. We did not have a collocated physician psychiatrist at their primary care clinic, but they will line up some cases for a half afternoon a week where they would staff some of the difficult cases with us, and in some cases we would just do a complete psychiatric evaluation and then propose treatment that they will in turn follow up with, and in some cases we continue treating them over time. And that experience allowed us to have some feasibility data saying, hey, there's this population that needs services. We have been able to deliver this care through telepsychiatry, these are some of the hypotheses we have. We believe that we can help these people do well. At that time, I was working with Jenny Chong in another study that she had a grant to look at the health the relationship of physical and psychiatric health in people seeking care at the rural clinics here in southern Arizona. And we were thinking, how can we collaborate? And here we are doing this kind of work through telemedicine. And Jenny, who has family all over the world and Skyped with them. This is the first Skyper I knew in the world was Jenny Chong. And she talked to her family in Australia, in London, in Malaysia, through Skype. And she thought, hey, why don't we just do this telemedicine through Skype? And it was a very intriguing thought. And she'll introduce the study to you guys a little bit better. And it really, I think, that sense that we could do this type of intervention, a psychiatric evaluation, psychopharmacological, and some psychotherapeutic intervention for people with depression through the regular internet services that we all use, through regular webcam, was something that was very attractive to RWJ, Robert Wood Johnson Foundation, and they funded a study for a couple of years to expand the pilot that we had and continue to have more data and see if we had enough to test the hypothesis that Jenny will tell you about. So I think without spending a lot more time on that, I'd like to introduce Dr. Jenny Chong. And my colleague Jenny has a PhD in human factors in psychology from Monash University in Melbourne, Australia. Worked in a number of fields, but the underlying theme is related to factors that affect health and well-being of the communities that she studied. Dr. Chong has been interested in telemedicine services since 1998. She was funded by the NIAAA as a PI to provide substance abuse aftercare treatment to Native Americans returning to the Indian Reservation. In 2007, we received the Robert Wood Johnson Foundation to assess the acceptability and feasibility of providing psychiatric care to underserved depressed Hispanics through the internet. She's currently involved as principal investigator in an Epilepsy Foundation project to assess the effectiveness of working with community health representatives to improve the continuity of epilepsy services to patients on the Hopi Indian reservations through telemedicine. She is also currently involved in determining the incidency of epilepsy in southern Arizona, as well as assessing the types of services and mental health issues among those who suffer from seizures. She's also continuing her work with Native American connections in Phoenix, Arizona, to determine psychosocial factors that predict substance abuse treatment outcome for adult males and female Native Americans. So it was very nice to take advantage of Jenny's expertise in the fields of telemedicine and the fields of working with underserved communities and her personal experience in chatting with people through Skype, and merge all of that, incorporating that into some of our experience in developing and executing clinical trials for depression and other psychiatric conditions that led to the current protocol. So please help me welcome Jenny so she can tell us a little bit about the protocol.
Am I tall enough? Hello. Okay, good afternoon. Yeah, we were very happy actually when Robert Wood Johnson decided to fund us, because this is, as you say, as Francisco said, that it's an interest of his. I wanted him to do it in Douglas, but he wanted to do it closer. And when the reviewers came, because they had this wonderful idea of what it's going to be like, you know, us in the city and them in the rural areas. And they were shocked when they found out that St. Elizabeth was really just about 2 miles away from us. But we felt actually in the end that this was a good thing, because if something happened and we needed to be there, at least then we know that somebody could be there to take care of those people. Okay, so we really, even though telepsychiatry has been done for some time, we really don't know how acceptable with the immigrant population, as well as, you know, the low-income Hispanics, minorities, because especially with depression and having to see a psychiatrist, those are all stigmatizing factors as far as they're concerned. So we need to know how feasible this is. And so in St. Elizabeth, as it turns out, turns to be the a perfect place for us to bring our lab, as it were, with them. Even though St. Elizabeth actually has already had experience in terms of telemedicine, because they have their own little telemedicine room and it's connected to the Arizona telemedicine program here. I was reasonably adamant that, you really want to do it through the internet. Not so that everybody could break into it and all that, but because if you really want to provide services out into the rural areas, not everybody has the initial dollars to get them set up with the ATP, the Arizona Telemedicine Network. And so I felt that, even when sometimes with Skype you have all these terrible images, etc., at least you're providing some kind of service. Having said that, our university then pretty much, I think, said, we don't know how secure Skype is. And that's when we then went on to this this old program now called Breeze, which the university provided for us. So in terms of feasibility of us starting this project, we were able to do it because we have something that supposedly is secure. And we also know that the administration at St. Elizabeth were very interested in doing this. They had been trying so hard to get psychiatrists and mental health professionals to their facility, and it was just difficult for them. Finally, actually, after we got the project funded, they managed to snag somebody half-time to provide mental health services. But even then, I think that poor woman was just totally overworked, to say the least, and they tried to give it all to Dr. Moreno when they can. Okay. So what we really want to see is whether it is feasible. And we calculated that we're probably going to need about 175 patients being recruited so that we could get a power of 80. But we ended up getting about 150. I think we recruited 168 and we got 150, all the data from them. What we did was to try and recruit from, we asked the physicians to refer to us, and we also tried to get all those people who come in, because they have to register every year, to come in and fill in a PHQ-9 form in Spanish or in English, whichever they want. And we would then go through to check to see, for those that are 10 and above, we would consider them screened in, and then we would do a second screening using the mini. And as you see, we also have exclusion criteria here, just to be sure that we don't have other things that we really don't want to be dealing with for this project. We only have Hispanics, even though we did screen the non-Hispanics, but we didn't use that data. We only used the Hispanic adults going through the St. Elizabeth. Okay, and I guess this could be the webcam that you used. I'm not sure. That's the model. That's the model. And that's him. And that's somebody else that I don't recognize. And we were trying to figure out what he had on his T-shirt. I think it says, "Keep talking, I like watching your lips move," or something like that. But anyway, so St. Elizabeth actually has got their own little room that they can use. And if you're interested in how we did we used Breeze to hook in with them, we could certainly tell you that later. When the patients get referred to us, Martha, who is our, what do we call her, recruiter, would talk to them and do the mini on them. And if they seem to if they qualify, then she would do the consenting with them. And at that stage, then we would randomly assign them to whether they are webcam or treatment as usual. As far as I know, nobody said no to the assignment. In terms of the treatment as usual, they basically just get the doctors, physicians to take care of them. The only difference is that originally we were going to not say anything to the doctor, but of course that doesn't work, because if they get assigned to the webcam, the psychiatrist would be giving them medication, and so you don't want the more in tune PCPs to be also giving them medications. That's just not going to work. So we had to tell them that so-and-so has been assigned to the psychiatrist. We also noticed that, if for those with PHQ-9 scores that are pretty high, we made sure that the physicians do know about that. Okay. If they got into the webcam, they have 6 sessions plus 1. They see the psychiatrist for the first time for 1 hour, and then after that is 30 minutes each time for the next 6 months. In terms of the treatment as usual, they just come and go, as they need to. Okay. In case you don't know what it looks like for the treatment as usual for the PCP, there's a patient and here's a doctor. And I don't recall smiling that broadly when I go to see my doctor. I usually am not that happy. But anyway, there you go. All right, now with treatment as usual, again, so the doctors are the ones who prescribe, and I know that sometimes they do talk to Dr. Moreno when they want some help in terms of not so much talking about the patients, but more like medications, etc. Am I correct? But not for the study.
They have to follow the guidelines. They always are supposed to consult with them.
Okay. For those who require more mental health services, they either refer them to Sister Michelle, who actually is half-time at St. Elizabeth, or if it's more serious ones, then they would send them off to the Regional Behavioral Health Authority. And that had always been a problem for them before this project, because you would refer them, and if it's not a warm handoff, those patients just don't turn up. And so you can imagine how nice it is for those patients who actually did get the webcam. If they had crisis service problems, then St. Elizabeth does have its own, so we don't have to take care of that. Okay, we had a heck of a lot of questionnaires for them. With the PHQ-9, when we first started, we wanted to use it as sort of an outcome, so you would do it at baseline. That is the screening, as well as the 6 month. But then as we started going through, Francisco felt that he wants to use that as his way of keeping track of his patients, so that he gets the scores when the patients come in. And so I thought, well, if that's the case, then I think all of our subjects should have the PHQ-9 whenever we get them. And the mini, as I said, that was just a screening instrument. Then we have the QLSQ, which is the, what is the QLSQ? Thank you, quality of life. Short form 8, actually that was, we proposed that, but we changed our minds. We didn't use that. We used the Sheehan Disability Scale instead. MADRS, that is, I think most of you know what that is. That is, it's not self-completed. It is somebody else, an interviewer actually did the rating. And this interviewer who did the rating is blinded to whether the patient was sent to webcam or treatment as usual. We have the visit satisfaction questionnaire. This one, we asked the patients after they've had their webcam visits, how satisfied they were. It's not so much in terms of how happy they are with the doctor, but more like the time it took for them to get to the doctor, the time it took for them, how long they had to wait at the waiting room, etc. And then we have the WAI, which is the Working Alliance Inventory. In this one, what we do is that we have the patient fill it out after they have had a visit with the doctor, and we ask the psychiatrist to fill it out. Basically, the questions are the same, except that they're talking, instead of I patient, it would be I psychiatrist, and I work well with this patient, or the patient, you would ask the patient says, yeah, I work well with the psychiatrist. We all have the same theme, that sort of stuff. The asthma is the acculturating rating scale for Mexican Americans. Because we wanted to see, since we were interested in seeing, whether the Hispanics are different in terms of whether they are more acculturated towards the Anglo versus non. Then we have other information, just your basic baseline information, and we also ask them how compliant are you with what the doctor asked you to do. After that, I think I'm going to ask you to do this. Oh, any questions? No?
All right. So a side effect of doing this was that we could have, at any given time in the screen, the picture of the patient and also our own picture. So it was very nice to see myself doing all the faces and kind of poking my nose and all the gross things that we do when nobody's watching. You have it right there. It's like doing therapy in front of a mirror. You're seeing yourself. So it was a very nice teaching tool. We also had opportunity to go and view them because we recorded a number of them that the patients approved so that we can test fidelity. And so we had some of our former residents and also Dr. Martinez who helped us with fidelity checking to make sure that we adhere to the protocol. And it was nice to see what we're doing. So it was a nice teaching tool for the residents and, of course, for myself. So in terms of outcomes, the MADRS is the Montgomery-Åsberg Depression Rating Scale, which is one of the gold standard measurements for depression outcome. And what we have here is this is at baseline, what patients had baseline scores, the ones that were assigned to treatment as usual, and their outcomes at 3 and 6 months. So what you see here is that they seem to have a little bit of a worse baseline ratings when people came in and were assigned to the webcam intervention, and they also seem to be doing better at the end. So the gap was more important here. So there was clearly a mean effective time, which means everybody got better over time. Not everybody, but in aggregate, subjects got better over time. And there was an interaction of the treatment intervention with indication that those that were treated with the webcam actually turned out to do better than those that were receiving treatment as usual. And just to recap, the webcam and the treatment as usual were rated prospectively for 6 months, and doctors in the primary care clinic knew that their patients were there for depression, and so did us in the psychiatry intervention. And we used the same assessment that we use in our outpatient clinic, which is a standard APA guideline-based type of intervention. And we follow the Texas Medication Algorithm project to treat depression. Jenny mentioned that I wanted to get a PHQ at every visit, and that's something that I cannot emphasize enough how important it is. There's a new movement in psychiatry for the last close to 7 or 8 years in which measurement-based treatment is really profiling to be the way to go. If you remember, Texas Medication Algorithm tells you we're going to be shooting for remission. And if your patient is not in remission, you have the rating scale there that's telling you how far are they from remission, and you have to adjust your treatment accordingly. I think one of the biases that we have in psychiatry is we get comfortable, and I think more so in primary care, and that was one of our hypotheses, that people received a given dose of an antidepressant and then I'll see you later, and we don't always go back and check how well people are coming up with, and sometimes reports like, oh, I'm doing pretty good, or I really like that medicine. It's enough to move on and not continue to be aggressively pursuing remission. So I think this was the main outcome that we were looking for, and we were very satisfied to see that with our sample of 159 people with about 150 completers, we had enough power to detect the difference. In addition to the continuum of response that people have, we were also looking at the categorical outcomes, remission and response. And remission response was defined as a drop in the MADRS of 50% or more, which is a very standard definition in most multi-site clinical trials of pharmacological agents, and 75% drop, which is not exactly an APA accepted definition of remission, but it's what Texas Medication Algorithm uses for that. And that's what's been used in large studies like STAR-D and other studies like that. And so what we found was, again, this is the proportion of patients that met response criteria, about 44–45% in the treatment as usual group versus about 60% in the webcam treated folks. So this was very nice also to hear, because again, this is a study that was looking at demonstrating feasibility and acceptability of the treatment, not to show that it was actually going to be people were going to have better outcomes with psychiatry treatment as well. And there's a few variables that we're not always controlled for that will bias the result of the study as well. But the same thing what we found in remission. About a third of patients treated in treatment as usual reached remission, and about 45% or so of the patients treated with webcam reached remission. So that was, if you look at the chi-square testing between these two groups, this was statistically significant on a two-tails analysis, less than 0.05. This one had a trend of 0.9 in the one-tail analysis. And what that means is when you're pretty sure that you're going to see outcomes going in one direction, then you can do one like single-tailed analysis because you know that it's supposed to get that way. But when you're not sure what's going to happen, it could go this way or the other way, then you do a two-tailed analysis. The two-tailed analysis in this case was not significant. It was like 0.125. So should we have had a little bit more, a few more patients, this could have perhaps shown difference for remission as well. But again, these numbers for remission are of course larger than the ones that you will see at most clinical studies, including longer-term studies such as STAR-D. So that was a blinded clinician rated gave us the MADRS outcome. This is a self-rated questionnaire. The PHQ-9 basically asks you 9 questions taken right out of the DSM-4. It's like, how's your sleep, how's your appetite, how's this, how's that, are you suicidal? All the depression symptoms that we see in DSM-4 are part of the PHQ-9. And it's a well-accepted diagnostic and outcome tool that continues to be used more and more, especially in primary care offices. And this is what we use to pursue outcome for patients. And when you look at the treatment as usual again, it looks very much similar to the outcomes on the MADRS. And again, the main effective time was very significant at a 0.01, less than 0.01 level. And the interaction of webcam versus treatment as usual, again, was significant, a better than 0.05 level. And this is nice because you are testing a principle of meta-sciences called multi-method assessment. So it's not only the clinician rated, but also the patient rated and different rating scales that are giving us a very similar outcome. So that was another nice outcome to be seeing. We didn't only see different methods, but we also tested different traits. So it's a multi-method, multi-trait assessment, which is kind of traditionally the more rounded and parsimonious way that you can go about trying to document outcomes for a given study. And this was also very nice to see that over time, people's quality of life actually improved. And we see here a clear growth from baseline to 3 months and 6 months on the treatment as usual, as well as the webcam. And in the aggregate, it was the main effective time. And in the interaction, there seemed to be a greater response for the patients that were treated on webcam as well. So we were happy to see that as well, of course. Disability outcome, looking at the Sheehan Disability Scale, we had, again, the same kind of outcome. patients that came in for treatment as usual had drops in their disability scores looking at social, educational, work, and family functions and health functions. And of course, it looks like the change from baseline to end of study was actually larger for patients that were treated on webcam. So again, we had a main effective time, meaning 3 and 6 months. It was clearly improving, but there seemed to be a better benefit for those that were treated with webcam as opposed to treatment as usual. Okay, so in terms of the patient-doctor relationship, the Working Alliance inventory, as Jenny mentioned, we filled it up ourselves, and the patients also filled it up. And this is looking at, do you think your doctor's got it right? Are you working on the same thing? Are you comfortable with the treatment plan? And are you guys connecting? Do you understand each other? Those kinds of questions. And so this is a scale that has been developed, standardized, and validated for a long period of time in psychological research. And so we basically adopted scales that we didn't have to do any work at developing, but rather used incorporating their use as being valid. And what we see again is the people continue to have improvement in their communication with their doctors over time, and the improvement seemed to be slightly better also for patients that were treated with webcam as opposed to treatment as usual. So again, we had nice outcome in clinician-rated, patient-rated depression scales, quality of life, and functional ability, and also satisfaction with the physician-client relationship that really speaks about acceptability and effectiveness, not only efficacy, of this kind of intervention. The visit satisfaction questionnaire, the VSQ, again showed that it was improving over time. In this case, there was no statistically significant difference. And the reason here basically is, as Jenny mentioned, this is a rating scale that measure, okay, how hard was it to get to the clinic? How much do you have to wait? How comfortable were you with X, Y, Z? And so there were a lot of factors that were independent of whether they came to see their doctor or whether they came to see us through webcam, which was located at the same clinic. They saw the same clinician who welcomed them and then sent them and did the ratings and whatnot. So we really didn't expect to see too much different on that one. But again, it's interesting anyway that we were able to measure that. And if nothing else, one of the concerns is, are people going to be dissatisfied with coming and sitting in front of a TV or a computer? Are people going to be uncomfortable with the audio, with the noise, with this, with that? And if nothing else, we could say that these folks were fairly apt at diving right in. They were a little uncomfortable at first, the majority of them, except for the young ones that are very used to this, but very able to roll with it. We had a variety of patients with different cultural backgrounds, people that have never really seen a computer before, to people that are on the computer all the time, and people were very able to accommodate to this. So, in summary, U.S.-Mexico border mental health is associated with unique stressors related to immigration, acculturation, and common socioeconomical issues. Providing screening and treatment requires cultural, linguistic, and literacy sensitivity. Specialized care is sparse, yet effective when accessed and properly delivered. And telepsychiatry services allow accessibility to specialized, linguistically and culturally congruent care with good acceptability and efficacy. And with that, I'd like to open for questions. Thank you. Yes.
Two questions are related. Is the frequency and duration of contact with the patient the same for the two different methods? That's one question. Or is it different? And secondly, what is your explanation for why the telemedicine approach actually seemed to provide a somewhat better outcome than the traditional approach?
Okay. Good questions and very appropriate questions. The difference, the frequency of visits was different. And we probably need to go back and look specifically at the number of visits. So that patients that came to the webcam, they were seen 7 times over the course of 6 months for that particular issue. Treatment as usual does not get that kind of frequency of contact and that duration of contact. The majority of patients, when they're coming to see their doctor, they're not coming to see them for depression. And of course, the visits that they have are going to be a bit different to the ones that we're having. On the other hand, as Jenny mentioned, as we got started with the treatment, the clinic hired a master-level clinician who was able to do different forms of intervention, individual psychotherapy, she was able to do family therapy, couples therapy, a number of other interventions. We need to go back and look exactly at the difference of the level of intervention that they had. But there was a much larger utilization of the services of the therapist at the clinic by those that were in treatment as usual than by those that were in webcam. And so I think it's an important question to address, and as we're getting ready to submit this for publication, we're going to have to go back and address your question, because I can imagine that the reviewers are going to go to that right away, and we ought to have a data-driven answer for that. And we don't have a data-driven answer right now other than our gut and our experience that it was clearly they saw Sister Michelle a lot more than the people on webcam. The second question is, how do we explain outcome? I think we follow different methodologies for treatment. Following an algorithm like TMAP and being loyal to a rating scale that tells you you're not there yet, and listening to that and pushing through is something that really allowed people to get better outcome in the long run. As opposed to going with the broader indications from the Agency for Healthcare Policy and Research that say this is how you ought to treat people and these are the dose ranges and whatnot. So I think that's part of the difference that have to do with the training of the primary care physicians as opposed to the psychiatrists to treat depression, as well as following guidelines that were different for the two groups. So we're not only testing webcam versus treatment as usual, but these other variables as well. John?
I was unclear when you mentioned the exclusion criteria, whether you were just selecting patients with major depressive disorder and nothing else, or were you accepting comorbid conditions such as major depressive disorder, let's say substance abuse? And if so, were you treating both conditions or just the depression?
Good question. People could have had a few other psychiatric conditions that were not supposed to be primary that led to a depression complication. We excluded people that were actively using substances, but we had a number of people that were in remission from substance abuse, including alcohol and other drugs. We excluded people that had schizophrenia or bipolar disorder, and those that were actively in need to be either hospitalized or in a residential treatment facility. But we had a number of people that had eating disorders, PTSD, different anxiety disorder, a lot of anxiety comorbidity, a lot of trauma-related pathology. So there were a lot of comorbidities with major depression, but we tried to move away from people that had, for example, severe seizure disorders, trauma, like TBI types of things or whatnot. So it was primarily what we thought should be a primary major depressive disorder, and could have psychosis, could have a number of other complications, but not a primary psychotic condition with depression or something like that.